to it directly, people will not get the essence of what you want to put across to us there. The objectives of this study were to investigate whether the word whether does not flow with the things you set out to put there, except you're talking to polish it up. That's why I said internally we will get on to do the necessary adjustment. Thank you.
Thank you, sir.
From your objective, if you want to use Roman figure, you started with Roman figure 1, 2, and 3. Is that not so?
Yes, sir.
Now, the research question supposed to be Roman figure 1, 2, 3. Do you understand? If you are using figure 1, 2, 3, that means the objective should be 1, 2, 3. Do you understand what I'm saying? It's not that you are going to use Roman figure for objective and use figure ordinary for the other one. So it has to correspond. Thank you very much. Next presenter. Okay. We are going to call on Victoria John Effiong for our presentation.
Good morning, panel members and distinguished colleagues. Standing on the existing protocols.
7 more minutes. 7 minutes.
I'm Victoria John Effiong. I want to present a paper with other authors on the research titled Holiness, Hygiene, and Human Dignity. Ethical Assessment of Leviticus, chapters 13 and 14, and implications for hospitality ethics and community health equity. Leviticus chapters 13 and 14, respectively, present a detailed priestly framework for managing ritual impurity through diagnosis, isolation, and reintegration, grounded in the theology of holiness and communal order. Scholars like Migrom, 1991, and Livan, 1989, have actually argued that the Leviticus function not as a medical manual, but as theological ritual framework. Hence, the study identifies critical and practical gaps in the contemporary public health and hospitality sectors. This gap is the insufficient empirical integration of biblical ethical framework. Hence, the study is proposing a model named HHD framework for this research. The objective of this study is to examine how faith informs ethical frameworks and to evaluate perception of isolation as impunity versus restorative. To explore how biblical holiness and impurity categories inform dignity center, identify anti-stigmatization strategies, among others. The research asks the following question: how do professionals interpret disease-related isolation? Does theological literacy influence ethical decision-making? What parallels exist between Levitical quarantine and modern public health ethics? How can biblical purity laws be reframed to support non-discriminatory practices, among others? Significance is to reintegrate Leviticus chapter 13 and 14 respectively as a restorative ethical provide frameworks for balancing safety and dignity, bridges the gap between biblical theology and contemporary public health. The research makes use of mixed method, that is the qualitative method. And in this research, 50 participants from each of these were selected, 50 from the field of theology, 50 from hospitality and management, and 50 from community and public health, respectively. The key findings are, number one, theological literacy significantly predicts ethical inclusivity, and the professional background shapes interpretation of isolation. Institutional stigma reduces support for inclusive policy. Importantly, isolation is understood in two ways. Number one, as protective care. Number two, as social punishment. Reintegration emerges as essential for restoring dignity and preventing long-term stigma. The proposed theory is showing that, number one, holiness should serve as a communal responsibility. That is to say, isolation as shared moral responsibility for all in the community. Then hygiene serves as structure protection, meaning it should serve as clear, fair, and consistent health protocols in the community. Then dignity is mandatory reintegration for all. That is to say, it should serve as ethical necessity. Then this will actually will serve as anti-safeguard, which will serve as policies for prevention of discrimination among those who are passing through leprosy, HIVs, and other diseases. The recommendation the study actually recommends the following. Number one, national authority should reverse quarantine and isolation policies to include mandatory reintegration protocols. Number two, tourism boards and hospitality council should establish ethical infection control guidelines that prevent discrimination, exclusion. Church health boards and faith-based hospital networks should embed restorative theological ethics into constitutional policies. Then medical, nursing, and hospitality accreditation bodies should integrate anti-stigmatization ethics and dignity-centered care principle into mandatory professional training. Thank you.
A round of applause. Clap for appreciate her, please. Let us appreciate her. It's not easy to present. It's not easy to present. Thank you. Any question? Question? Question from the audience. You have question?
No question really, except that in terms of the volume of what we have, okay, the paper. Okay. In terms of what we have here, by the time we comply with all the rules guiding this kind of paper, we will have extended into some 60 pages or thereabout. But then an abridged version of what you have presented will probably, align with what it's supposed to be. But it's a good, the details are just numerous, but then it's a good job you have done. Thank you.
Thank you, sir.
Next presenter. Who's the next? Number 3. Olatishe Bintu. Please clap for her now.
Good morning, the honorable panelists and my able colleagues. I'm Olat Shebio. I'm here to present on improving access to emergency obstetric care in Nigeria. Then, the contribution of community health practitioners. I have here the introduction, the review, discussion, method, result, and conclusion. Under the introduction, Nigeria's maternal mortality crisis, the numbers that determine the actions. 1, we have 14% out of 100% of all global maternal deaths came from this our Nigeria. Then we have 1,047 maternal deaths per 100,000 live births as of 2020. Then 40,000 Nigerian women die from pregnancy causes every year. That is 109 women die every day, nearly 5 every single hour. Introduction continue. What is exactly emergency? This is the critical clinical interventions for life-threatening pregnancy complications. That is 9 signal function. When promptly deployed, prevents up to 80% of direct obstetric care. That is, it's just an intervention from health workers. We have 88% of direct maternal deaths, which is preventable with timely emergency obstetric care. Under this one, we have the 3 delays model. Number 1 of this delay, deciding, that is recognizing obstetric danger signs, that is overcoming financial, based on their cultural belief. They know that this is problem, but based on their cultural belief, financial problem, they will just decided, I'm not going. God will do it. Jesus will do it. I will soon be lying. So we have another one, which is reaching a facility. Most time problem too. Then the distance, when they are living where there's far to the health facility, that could be a problem to their own side. Then we have receiving appropriate care. That is inadequate emergency obstetric care capacity at facility. That is absence of supplies, untrained staff, then equipment failure. All these are problems. Most time there may be staff, but there won't be instruments. Most time there will be instruments, but when there is inadequate numbers of staff, there will be a problem. Then 70% of pregnant women's first contact is a community health practitioner, because they are living in that community. They are living with them, they are working with them. Their first contact, they are very easy to locate. These community health practitioners, we have the JHU, we have CHU, then we have CHO. Thank God we have BS, Masters up to PhD level now. The methods, study design, comprehensive narrative review. Study design, synthesize heterogeneous evidence, randomized twice experimental study. Number 1, who signal functions framework for emergency obstetric care. The 3 delays model, then WHO health system building block framework. The thematic synthesize, that is 4 analytical cluster. Number 1, epidemiology and contextual determinants of maternal mortality and emergency obstetric care access. Number 2, community health practitioners' current roles, capacity, and scope of practice in emergency obstetric care. effectiveness of team, technological intervention, and implementation challenges, facilitating factors, and health system determinants. The methods now, database source, the PubMed, the GNI, the M-base, then Web of Science.
3 more minutes. 3 more. Just go to your methodology, for your findings. Just brief us the method you use for your then your findings and recommendation. Thank you.
Under the discussion, evidence of community practitioner capability. Number 1, according to SALT 2021, under discussion, transport mobilization, emergency auxiliary care chatbot, then innovative tracking tools enable evidence-based facility planning and geographical access optimization. The 3 imperative with crystalline clarity. Number 1, fully operationalize tax shifting and tax sharing policy. Number 2, sustain investments in primary healthcare infrastructure, supplies, and referral systems. Number 3, recognize, compensate, and support community health practitioners. Under the recommendation, for the government side, government policy, develop and implement policies empowering community practitioners to provide timely emergency auxiliary care identification, management, and referral. Invest on functional referral system that is reliable communication network and emergency transport scheme. Under the health worker side, we have promptly identify auxiliary danger sign and ensure timely referral to higher level facility. Then maintaining strong coordination across all levels of care with effective stabilization and handover. Under the community stakeholders, they are to promote awareness and maternal danger signs and encourage early, regular antenatal care attendance. Then they are to support timely decision making to obstetric emergencies without delay. Then they are to establish and support local emergency transport and savings schemes for maternal emergencies. Below are my references.
Thank you. Any question from the audience? Questions? Mommy, you have a question? Question? That's it. What is your question? I should ask you. Question, please. Yes.
I believe you had a set of data that you analyzed in making your inferences and all that. But when you started, you were so emphatic about year 2020. And I was going to ask whether there are no data, no information available for, years beyond 2020. But by the time you got to the methods, what you put on the board, you have a span of 2019 to 2025. So I just want you to tell us exactly what is your data. You are referring to which period? Are you stopping at 20 or you are stopping at 2025? Thank you.
Thank you, sir. As of 2020, we have 14% of all global maternal. Then Nigeria have 14% out of all percent globally. Then we have 1,047 maternal deaths per 100 live births.
2022, 2023, you don't
Based
have...
on the intervention of community health practitioner, there is changing, there is improvement, there is reducing in maternal mortality rates.
Clap for her. You know, when you are presenting, there are some terminology, concepts that you need to mention. That's what you wanted to hear. Deduction.
Thank you, sir.
Not change. When you say positive, might be negative.
Yes, sir.
Do you understand?
Yes,
so
sir.
change.
Thank you, sir.
Thank you. You can have your seat.
Thank you, sir.
Please clap for her. The next presenter, Olaguju Oladuni. Okay. Oh, okay. I think he has presented before. 4 papers to present. Now, please do not forget to pay your publication fee, your abstract, or what do you call it, 5,000, right? 65,000. For presentation 30,000, publication 30,000. Then the peer reviewer 5,000, making 65,000. I hope you have all paid.
Yes.
So that's very good. Because if you don't pay, your paper might not come out. So please make sure you pay your money. It's going to add, the paper is going to add more value to your education. Thank you. Over to you.
Thank you. Once again, I stand on the existing protocol. My paper presentations based on burden of pelvic organ prolapse within the community obstetric care outcome in Nigeria. Yeah. Now, when you are looking at that, people will believe that why these boy guys like women per se. I feel for them. Yeah. You know, when you are talking about the pelvic prolapse, it's not easy for a woman to carry a pregnancy for 9 months and something will come out from their pelvic organ. There will be a shake. Now let me go straight to the point. We have backgrounds telling us that in sub-Saharan Africa carry the highest regional pelvic burden globally. What that means to us, you know, descending of our one or more pelvic organ, uterus, bladder, rectum, and vagina into beyond the vaginal canal due to pelvic floor weakness or damage. With one of the continent highest fertility rate, despite high epidemiological vulnerabilities, Nigeria's specific populations are based on that data remain sparse and fragment. Where we have a lot of GAD, that is not sensitized as specifically center, especially Nigeria, despite the fact we still have burden. Now, communities obstetrical provision of maternal health services within the community setting. We all know that there are frontier health worker that is render health services. Yes, we have collaboration, but majorly in rural area. They are the one that do it. Then they still also have community health worker. We have BHS and so on. Then we have tax shifting approach. Then we have hybrid. My objectives based on to determine the pool prevalence of pelvic obstetric care among the women in Nigeria comparable Africa community obstetric care setting. Then identify and qualify the socio-demographics or focus associated with POP across included this study. What are the methods? I like systematic approach. You know, I want to know what Mr. B and C to Z talking about this before I will make my input. I use systemic review meta-analysis, Prisma 2020 guideline, as I do. Then my publications period of looking at this based on 2022 to 2026, based on scholars, Google Scholars and PubMed. That is that. Then, I consulted 847 journals. But at the end of the day, my study based on 12 journals. 12 journals. Now, by that, I have a qualities assessment and statistic analysis of the study. Then, what are those my results? In 12 studies, included in final synthesis, I have a lot. Look at 25% in Nigeria having issue of pelvic obstetric below obstetric. Then we have 42%, Uganda 1%, multi-country global they have 22%. That is, this POP's proxies is prevalence 22% across. In Anambra they have 22.4%. Among the older women, they have it result time to urinary incontinences. It is a problem. Our mothers are having an issue based on this POP, pelvic obstetric. Then also we look at it in Southeast. Pelvic floor mobility incident is what? 31%. Track women through the pregnancy and what? Postpartum. Track the pregnancy and postpartum. Then Northern Central in Nigeria, barrier to care, it make them to stigma. It be a stigma to them. Then financial, cultural, contextualized also is based on that with my data. Then poor prevalence of pelvic organ prolapse, 24% poor prevalence. Then we have all this is there based on 34 grand multiparities, 33.6 no skilled birth attendance. Then also we have 26.1 that's slightly above. That is Nigerian specific study. That is that. Okay, because of my time, we still have a lot that
a minute more.
Thank you. Also, let me move to discussion. Grand multiparity, yes, is a central risk driver. 38.4 prevalence among the multiparous women. Yeah. Community care as mechanism. No, at the delivery rate, they need strong protections role of skill care. Then we have socio-demographic grading. Then community obstetric care as a preventive framework at this junction. That is why I still channel my recommendation to Nigeria as whole that community health practitioners need more in any work, then sensitization about to guide our women in safe delivery. Thank you.
Thank you very much. Contribution. Don't let me ask this question again. Any contribution? Maybe you have something to contribute towards what he has presented. Contribution, please. Thank you.
Thank you. Can't remember your name now, but you've done a good work. We came to the conference to learn anyway. I just want to say concerning your slide, not only you, the others. I know it's sometimes it's beautiful. In science, I'm from a science background. It's about the information you want to get. It's so tiny that I cannot see the colors that are underground, that the background are not reflecting those
Clarity and
letters.
sharpness.
So I'm just trying to view, but I can't get. And most of us, if we don't see you, at least hear your word, but we can at least get some things from your slide. So we can't see them well. The letterings are too small, and the color, they are colorful, right? Which makes it beautiful, but it's more of what we want to gain, not what we want to see. So that's about that. And I also, so for somebody like me, from this work, what do you want me to learn? Or what do you want it to be a take home for me?
Thank you. What I want you to learn is that for the viewers, it is very, very important to pregnant visit the health care centers. Based on the word is available to you, primary health care, secondary health care, and tertiary health care. We should stop patronize the quack and order that doesn't have the ability to guide your pregnancy delivery. Thank you.
A question for you here.
Well, your title, you probably will need to reconstruct it properly, because except for the fact that you're speaking to this paper now, it is when you started speaking that I got to know you were talking about Nigeria. And you started your introduction by mentioning sub-Saharan Africa, referring to all of those. Now, then you surprised me by saying your data availability covered 2022 to 2026.
Yes.
Is that really correct?
Yes.
From which source were you getting your data from?
Thank you. From PubMed, I got my journal from that. Then also from Google Scholar, I got my journal from that. That is why I said that all the journal that I collected together is 847. At the end of the day, I'll be able to sort it out. Getting 12 journal, that is where I got mine.
Okay, I don't have any problem with that.
Thank you, sir.
Now, because we are still in 2026,
yes,
and we have not gotten to the first half of 2026.
Even though some journals has come out.
Please.
Okay, sir.
Leave 2026 out of it.
Thank you.
And then stop your data analysis.
My prof, thank you. Thank you, sir. Thank you, sir.
Any other question, contribution? If there's none.
Contributions.
Okay.
Thank you, sir. One thing I want to contribute is about a woman. Before we get pregnant, you know already how you are, how your body feels. So there should be more sensitization on women after birth, maybe during their postpartum care, that they should know whatever they feel in between them, maybe abnormal, maybe they feel any inconveniencing in their body. So there should be more sensitization on that, so that they'll be able to come and tell the healthcare provider that I feel somehow in my body, so that more examination can be done.
Thank you. Thank you.
Thank you, presenter. My contribution is just in tandem with the last speaker there, the penultimate speaker. He spoke about the fact that during presentation, most of the things on the screen they're not legible. You can't read them. This is a piece of advice, not only to you, to other presenters here. Given that the crowd and the auditorium could be very big, it would be advisable most times for presenters, particularly if you are coming from data science point of view, to use pie charts. Because with pie charts, you can see it as a glance. This is percentage of this, percentage of that. Because when they get too wordy like that, they are not legible. And the media is the message, according to mass communication theory. So that people can see, they can relate to your diagram and pick your information just at a go. Thank you.
Thank you, sir.
Thank you very much. The next presenter, Dr. B.R. Adowiti. Over to you.
Duly observed. The paper I'm presenting today is titled Brain Drain, Health Law and Community Survival, Regulating the Migration of Health Professionals in Nigeria.